feel free to have your comments. It's a discussion, debate. It's not particular, it's not presentation as such. It's just find the answers to the questions, right?
And if we could all just speak really as clear as you can and concise so that the listeners can hear what we're all saying.
And straight to the point.
And straight to the point.
Okay, I'm going to go for it right now. Let's have a good one, people. Thank you very much to everyone. Ooh, right. It's coming up to 5 o'clock and we're live, and I can see the participants numbers are going up rapidly, so we'll wait a minute or two for everyone to join us. But those who are joining us in real time, we're nearly 100 participants already joining us. Thank you very much for being part of the ACLT's webinar today. I'm just going to wait a few minutes once this number moves. We're already at 150. So for those who are joining us nice and early, this is the panel of specialists and patients who are going to hopefully enable us to have a really constructive debate. But we'll just hang around for a few minutes and wait for as many of the patients and people to come through. Someone's ringing my phone, as happens. So, but Charlene and Claudia know all about that, and interruptions and on live coverage. Right, just closing on 200. So we'll just give it a minute. Right. As we're just about ready to go, we're at the 200 mark, and people are joining us. There's Claudia as our moderator in charge. I just want to say thank you.
You're in charge, you and Beverly, but yes, go on.
Just really want to say thank you to you and to Charlene for being our head honchos and keynote speaker on today, and also to all of the health professionals who've given up valuable time, precious time, and the patients who are involved in this as well online and in this webinar talk for being here.
Also want to say thank you on the legal side. We have Mr. Terence Channer. We're going to introduce everybody very shortly, but just to say thank you also to you, the registrants, for coming on board. Hopefully we can answer most or all of your questions. And I can see now that Andrew Cole has just joined us. So thanks, Andrew.
Yes, Mr. Cole, thank you very much for being here. The Manchester United head. Welcome.
No problems.
Thank you so much.
We are at 236.37 and it's going up 40 people online. So should we get going? Are we all ready to go?
Yep.
Yeah.
Okay.
Okay.
Let's go. First of all, because it's a jam-packed webinar, we might go slightly over our time limit. So I apologize in advance because we're going to try and cram a lot in a shortage of time. We have put this on the ACLT. Myself I'm Orrin Lewis. This is my wife, my partner, Miss Beverly DeGale, and I spent the last 25 years running the ACLT to try and save lives. And we've been successful. It's been difficult, it's been challenging, and but we succeeded, and we found many donors along the way to save many lives. And I just asked, someone's got something, we're picking up an echo from somewhere, so not sure where that's coming from. Okay, it's gone. So why are we doing this? Because of the hesitancy, as we know, out there in the community on taking the vaccine, whilst there's this incredible pandemic going on. Now, what we want to highlight is that the hesitancy that we've been hearing for the last few months about the vaccine we've heard this time and time again in terms of blood cancers for stem cells, bone marrow patients, for blood patients, we have sickle cell patients, thalassemia patients, and organ-related patients. We've been hearing this from the Black community for too long. And so we really want to say, look, let's now do something about this and change it. So we put this on, and just want to highlight our thanks to Amjad Ali, Kidney Care UK, the British Islamic Medical Association, Dele Iduru from Gift of Living Donation, which is also known as Gold, for their background, behind the scenes work to enable us to get some of the content that, out there to deliver to you. So Chris really wanted to highlight that, and Beverly's going to quickly talk about the next part.
Yeah, so during the webinar, please feel free, post your questions to the panelists using the Q&A button on the screen. I think it should be either at the bottom or at the top of your screen. Questions can be upvoted by clicking the thumbs up next to the question. And as many as possible of these questions will be answered as we go along by our panel of experts. We've got some great doctors who are going to be answering all of your questions on our behalf.
So the webinar lasts for 90 minutes. It's going to be it is being recorded and available at a later date. And in fact, I'm going to just ensure that it goes via Facebook and YouTube as well. We'll post it on there. That basically is it. So yeah, as we start, there's a question we want to ask everyone, for all the viewers, and we're at 300, closing in 350. I'm actually going to wait a bit until I get to the maximum, because I want to show a poll. I want to get everyone's views, how they feel about the vaccine. I want to get a snapshot of it at the beginning, but I'm just going to, we can see the numbers going, but we want to get a bigger audience. So we're going to introduce our first guest.
Okay, so we want to introduce Miss Charlene White from ITV News and from ITV's Loose Women. Charlene is an ACLT ambassador. She's been with us for 12 plus years, supporting the work, but Charlene's leads from the front, really. And we want to say, first of all, thanks, Charlene, for joining us today, but also thank you for being our keynote speaker to talk about why this subject matter is so important to you. So I'll hand over to Charlene White.
Thanks so much to you both, and thanks to everybody who is who has logged in and who are currently in the process of logging in to take part in this session. Anyone who knows the work that I do know that I am on TV in less than an hour's time. I have to be in the studio in about 20 minutes time, but I have, having already done Loose Women this morning, but this is important to me. There is a reason why I've taken 10 minutes out of what is a really busy day in order to take part in this session, because giving people more of an understanding about the COVID vaccine, about the importance of the COVID vaccine, and to dispel myths and to be able to answer questions that so many people have, I think that is important. I'm a Londoner, I live in London, I present the news for London, and I know about the hesitancy that exists, not just in the Black community, but especially in the South Asian community where the vaccine is concerned. And there are so many reasons behind that. There is a myriad of reasons behind that. And it's, for a lot of us, it's not a huge surprise that that hesitancy is there because of the history and because of racism that exists within the society and how that generally impacts health when it comes to ethnic minorities within this country. And there are questions regarding that do very much need to be answered. But where this vaccine is concerned, what the ACLT has done here today is to be able to get together a panel of experts that hopefully will be able to make you guys who are watching feel a sense of security where this vaccine is concerned. I have family members who I have had to convince to have this vaccine. My aunt, from the very, very start, a year ago when this all started, she was very, very, very adamant that she was most definitely not going to have this vaccine. She is an educated woman. She is retired. She's one of the most intelligent women that I know, but even she was incredibly hesitant and actually only changed her mind 3 weeks ago. A lot of that had to do with the fact that myself, my brother, my sister, my cousins, none of us was giving up in terms of trying to get her head around this. There's a lot of her concerns that I could understand, but I know the facts. I have looked into the facts of this, and this is something that we do every day on this, on my programs that I do, in terms of trying to give people more of an understanding of what COVID is and how important this vaccine is. The reality of it is, I have lost family members to this. I lost family members in the first wave. I lost family members over the summer. I lost family members over Christmas. My friend lost his mum on Christmas Day. Another friend of mine lost a parent the week after. A friend of mine, a mum friend of mine, lost her dad just last week. I struggle to think of a day, a week, or a month of the last 12 months since this kicked off really in March last year. I struggle to think of a month or a week where I don't know of somebody who has died. That is the reality of living as an ethnic minority within a city such as London that has such a large minority community, that actually I struggle to think of a month in the last year where somebody hasn't died as a result of COVID. And I think there's probably a part of me that hasn't grieved properly for any of those deaths, because it just feels like a tsunami of death over the last 12 months. And I don't particularly want to go through yet another year of that. I don't want to have to catch up with yet another friend to be told that they have lost another parent, or that they have lost an aunt, or they have lost a friend, or speak to my dad where he calls and said, oh, did you know that such and such, one of his friends has passed? I don't know about anyone who's watching, but I do not want much more of this. Death is hard enough at the best of times. Death during a pandemic is cruel, it's vicious, it's lonely, and it hurts way more than grief does outside of these last 12 months. And when I talk to you about it, I feel emotional, because that is how tired I am of it. And that is why I am so passionate about trying to dispel those myths that I know are being shared amongst your WhatsApp groups, that are being shared sometimes amongst your social groups, amongst your church groups, amongst your mates, just being shared. And I think we, you know, in terms of asking those questions, and in terms of not always believing what it is that you were told, I have an inquisitive mind. I have an inquisitive mind myself, but there is a difference in just believing everything that is sent in your direction. What's important is you look at that information yourself. You seek out those answers yourself from medical professionals, of which we have got a ton of medical professionals on this Zoom right now, and I really, really hope that you understand the importance of this, and that none of us that are on this call are trying to sell you lies, are trying to harm your health, or in any way are part of some mass conspiracy to vaccinate people with something that is just going to make them drop down dead. It's so important that you understand that none of us on this call are trying to do that. We are trying to save your life. We are trying to save the life of your family members. We are trying to get us out of the hellhole that is this pandemic, and try and get ourselves back to some sort of normality. I really, really hope, and I know how hard it is, because I work with a girl here whose family is Ghanaian, whose father had COVID about 3 weeks ago. Despite having COVID 3 weeks ago, still doesn't want to have the COVID vaccine. It is like an uphill battle where every time you think you've bashed through one wall, another one comes up, and there's another reason why someone says they just have no interest in the vaccine. I hope by listening to us all, none of us are being paid to be here, just so everybody knows who's watching. We are not being paid by some mass conspiracy to talk to you about this. We're doing this because we care. We're doing this because we see it as being important. And I don't want anyone watching to feel like I'm lecturing to you. I've just had enough. And I don't want to lose more people. And I don't want to have to keep dealing with grief. I've had enough. So it's really important that people who are watching understand that this is something we are passionate about. And I get it. I understand when people ask questions. Asking questions is a good thing. That is what people on this call are here for. They're here to answer your questions, but please believe them when they give you those answers. please believe them. These are people who know what they are talking about, and they are also, we've got doctors on this call who've been dealing with death at a level that they've never had to deal with before in their entire careers. They want this to stop too. So listen, the wonderful Claudia Eliza, my colleague, is going to be marshalling all of this and helping to navigate you guys through this. And I really wish I could stay for longer on the call, and I apologize for getting emotional, but that is how passionate I am about this. And I will continue to shout from the rooftops about how important this is, because I just want people to understand, and I just want people to stop being afraid. And I kind of want to get out of this. And I know all of us want to, but the only way that we are going to do that is by doing it together. So thank you so much for having me, Orin, and thank you for asking. I was saying earlier that I just can't say no to Orin. He knows that. And he knows where my passions lie, and he knows how passionate I am about so many things, but especially about the community that that raised me. I am passionate about the community that raised me, and so I will always lend a helping hand. And especially on this, I just need people to understand the truth and to do the right thing.
Thank you.
Thank you so much.
Thank you, Charlene. I wish I could give you a cuddle.
Really appreciate that.
Yes.
It's fine. I'll be in the studio in 15 minutes and I will redo my makeup. And anyone who's watching, he's based in London, when this finishes at 6 o'clock, it'll be like I didn't just have a meltdown on a Zoom call.
Thank you so much. I really appreciate that.
Thank you.
Thank you so much.
God bless you, Charlene. Take care. See you soon.
Just before we move on, I just really want to highlight that this is to the panelists and also to the attendees who may be asking questions through the Q&A. There's an expected level of etiquette, respect from us to you and you to us in your questions and in the discussions that take place, whether you're for or against the vaccine. Okay, we just want to make sure that everyone leaves here with informed information to make an informed decision. Yeah. Before we start, and I hand over to our moderator. We've got a question to ask of the audience, because we've got a sizable audience there, and it's a poll question. I'm going to give everyone 30 seconds, about 30 seconds to answer this question that I'm going to launch. This is for the attendees, so please go for it.
The question is, before we start the webinar debate, if offered, will you take the COVID-19 vaccine?
Few more seconds.
The panelists, you do not have the option to answer this question.
And here we go.
Right, here we go.
So I'm going to share the results. And as you can see, yes has 40%, likely 22%, unlikely 21%, no 17%. So quite an interesting mix. In fact, I'll make a note. Yeah. And 22,
22, 21, and 17.
Okay, that's interesting to see.
Yeah.
And we'll see what it's like at the end. Okay, so without further ado, I'd like to introduce our moderator, Channel 5 News caster, but not today. Thank you very much. Thank you very much, Claudia.
Hi, Orin. Hi, Beverly.
Thank you for joining us.
Not at all. Thank you so much to everybody out there who decided to tune in. This is a huge discussion that needs to be had. I don't think there's any much more I can say following Charlene White's keynote speech, and her own experience, I think, is enough to really, it's the best way to start this discussion. But all I can say though, that this is a discussion, that this is about listening, talking, having a constructive conversation over the issues surrounding the pandemic, surrounding the vaccine. And so for that reason, we just ask that, everybody just be very respectful. I ask the panelists in your answers to the many questions that we have and many questions you've got coming in, if you can just stay to time as much as possible. But yes, all those out there who have tuned in, who have logged in, who want to hear informed discussions, facts, not fiction, not rumours, not hearsay. We have medical and healthcare professionals who I'm going to introduce to you now. So first up, we have Dr. Asher Williams, Presidential Postdoctoral Fellow at Cornell University in New York, of course. Andrew Cole, of course, ex-Manchester United and England professional footballer and kidney transplant recipient. We have Dr. Huzaifa Adamali, who's consultant respiratory physician. Chanel Taylor is a sickle cell patient and she's needing regular, well-matched blood donations. Dr. Phil Bright is a consultant in clinical immunology. Also with us as a panelist is Reverend Eve Pitts from Holy Trinity Church in Birmingham. Also here is Dr. Faith Uwadia, who's an immunologist at the Francis Crick Institute. Vanessa Taylor is a leukemia patient needing a stem cell or bone marrow transplant. Dr. Elvis Ngasa, he's an organ transplant surgeon at the Manchester Royal Infirmary. Also here is Anthony Cox, personal development mentor at 100 Black Men of London. Terence Channer is a lawyer in human rights against police and health diligence. Dr. Linda Bello is a family physician. She also joins us today. Dr. John Ayuk is a consultant and service lead for endocrinology. Am I saying that right? At University Hospital Birmingham. Thank you for joining us. Dr. Valentine Ngwa, who's a consultant physician as well. We have Dr. Harry Price, who's a hematology specialist and also works with Anthony Nolan Trust. And Mr. Tony Cox, he's an LCT volunteer and mentor. And just to say that Dr. Price and Mr. Cox joined us last minute and confirmed that they can join us to be a part of this important discussion, which is why you don't see their details on the PowerPoint that you're seeing there. So look, we've got a lot to get through, a lot to talk about. Before I start putting your questions to the panelists, let's look at an actor who has something to say about COVID, largely because he's experienced it himself. Actually, this is an actor who I saw just this week. Tomorrow Never Dies was on ITV the other night, and he was on it. It's Colin Salmon. He actually was diagnosed tested positive for COVID-19, and this is his video talking about his experience.
Hi. Owen has asked me to just talk a little bit about my experience with COVID. I went down with it over New Year. I went on a drive-through test on the 2nd, and it tested positive on the 3rd, and I went straight into isolation. Well, I went straight into isolation after the test, actually. Tough joints, throat, headache from hell. Felt somebody put an axe in my head. Struggled to eat, drink. And my son, who also went down with me, but had a milder case of it, was really my wingman. He just kept coming in and checking my SAT. My wife is struggling, Fiona is struggling herself with an ILD at the moment, so we've been used to working with inflammation in the lungs. So I learned a little bit more about what she's going through, actually. The ambulance came out on the Saturday, and I was taken to Charing Cross, where they found I had a huge D-dimer rate, which makes me susceptible to clotting and things like that. But ultimately I had nothing, heart of a 20-year-old, sent home. On day 10, on the Tuesday, the ambulance was called out again because my breathing was more difficult, and they took my SATs. And again, the oximeter I was struggling with the oximeter. Now I'm showing the little finger because when I went into hospital that night after being rushed in, the consultant put it there because she realised that because of my past as a labourer and working in the butchery in hot water, my pads are quite tough. So please be aware of that. There's also the melanin in the skin, and the nail beds can sometimes not help with the reading. And any fake nails, which I don't wear anymore, no. But seriously, that can also affect it. So for people in BAME, in the BAME culture, black and Asian, or people with melanin in their skin, be aware that the oximeter can sometimes struggle to read. As I said, I was taken into hospital, rushed in, because I did the sit-to-stand test, and normally in the sit-to-stand test, the oxygen rate goes up. But when the inflammation hit me on the 10th day, my SATs went down, so from 92 to 90 to 80, and I was just rushed in. It wasn't a big drama. It wasn't respirators and people in masks. It was A&E at St Mary's, and I was in a room with 6 other people who were clearly all struggling with it, but it was so deathly quiet because we were all very, very poorly. A wonderful doctor came on duty, and she gently worked her way through, and she eventually took a arterial blood test. She had to do it twice, actually, really bloody sore, but by then I didn't mind. But within minutes of the results, I was in a bed on oxygen with steroids, and within 16 hours I was home. But if I'd have missed it, that would have been massive. I can't tell you how much I would say, and I had to fight I don't know what it is, it's just, whether it's working class or a male thing, but I have to stop saying, I'll be fine, because this thing, you won't be fine. This isn't normal. This is different. This is powerful. And a bit of self-care is important. And in fact, a very good friend who is a respiratory consultant, doctor, whose own father died in his ward last April, one of the early cases. From talking to him and anecdotal evidence, you know, he pushed himself too hard in his COVID experience. It could have been a lot worse, much more like mine. I think one of the things I would say about people who are worrying about taking the vaccine, and I've heard a lot of people talk about it, and people afraid. We have, as parents of Black and Asian community and just parents of people, our children have worked hard to become part of this profession, and we've got skin in the game. We have people working in the game. In fact, I think the vaccine itself was created by a Muslim couple. We are not in the 50s, 60s. This is 2020s. And we have moved a long way as a community, and we have to respect and take a lot of encouragement from the fact that we have experts and scientists and doctors of equal standing in the sphere, and we would not put our children and our parents at risk. This is not an old story, this is a new story. And I think somebody once said to me, the trick with the devil was to make you believe he didn't exist. Well, I think the devil's changed his skin a little bit, and I think he's now moving in mysterious ways to sort of suggest he does, but not in the places you think he is. Does that make sense? I think so. Don't double guess yourself. You ask any medical professional what they're going to do, and they will tell you. They will take the vaccine. I'm due the vaccine. I've just been away working, and I'm due it. And I've been told once I take it, it will double my antibody. It will give me even more resilience. But this is something that's potentially something we're going to live with. This is a COVID. I hope this is helpful. Please listen to the conversations that are coming, because this is not hearsay. This is facts. That's what I experienced. And I share it with you, not in a panic sense, but just to sort of say, I could have sat on the sofa and pretended I was okay, and then I might not be here today. I realize I have a phobia of ambulances. I didn't think, when I was taken away, I had tears rolling down my eyes, but I'm scared, and it's okay. It's okay to not be okay. And you are somebody's loved one, so please, act responsibly. And it makes a difference. And just to add, I've just got back from Barbados. And if you want to see a culture that's taking it seriously, they've had 30 deaths. And last week, they lost a child. So this weekend just passed, from Friday to Monday, there was total lockdown because they don't want to lose their people. They are serious. And that heartened me. And as difficult as it was for us to finish our film, it was the right thing to do. Because you're valuable. That's it. Go well. Thank you.
Thank you very much, Colin. That was very, very powerful. It's hard to sort of follow that. But I'm going to hand back to our moderator, Claudia, to take it on from here.
Thank you, Orin. It was very, very interesting listening to Colin from my perspective, because I actually tested positive for COVID in December as well. It is the illest I've ever been in my life. I actually haven't shared that. This is the first time I've made that public knowledge. Only my nearest and dearest know. In fact, Charlene White I spoke to when she asked where I've been for the last few weeks. I was sick for 3 weeks, the headaches, the pain, and that's then how Colin described it. You say you're going to be okay, you say you're going to be all right. And the truth is, I didn't know what was going to happen to me. Every day I thought the next day I'll be better. I was in limbo. But the issue isn't, or largely isn't, whether COVID is real. There are some people who have those questions, but we can say, I can say confidently that most people know COVID is out there. Most people can accept that it can be deadly. The main issue is the fears and concerns people have over the vaccine. And these can be legitimate concerns. This is a vaccine for a virus that we didn't even know about, hadn't heard of a year ago. So let's start dealing with some of those concerns. Andrew Cole, if I can go to you first. Now, what are your concerns as somebody who's had a transplant previously?
I think my concerns were just how quick the vaccine come about. And for me personally, regarding how is it going to help someone like me in my position? I've had this conversation earlier on today with Michael Van Tam. So I spoke to him earlier today regarding if I don't want the vaccine and everyone around me has the vaccine, no doubt he'd make it easier for people like me just to continue without the vaccine. He agreed with that. He did say, yeah, it should be better.
Sorry,
for
Andrew.
like you.
Sorry to interrupt. Who did you say? Did you say Michael Van Tam?
Yes, I spoke with him today.
You mean Jonathan Van Tam?
Jonathan, yes, sorry.
Oh, here we go. I just wanted to make sure you did ask about the deputy medical officer. No, please. I just wanted to make sure we got that certainly. Yeah, please go ahead. That's amazing. You actually spoke to the man himself. So what did he say to you? Yeah,
but he's advising me to take the vaccine. But like I said, I was just breaking down certain scenarios. You know, being a person in my position who's had a transplant, you know, naturally I wouldn't know how I'm going to react after having the vaccine if I do decide to have it. He said that shouldn't be a problem, you know, but everyone reacts in different ways, you know, which I stressed to him, and he said he understood that as well. So like I said, I was just breaking down many different scenarios to him regarding the vaccine, you know, and it was a good conversation. It was a conversation that did give me food for thought, but still thinking about it, the position I'm in now, me personally, I don't think I will have it. I'm not going to lie. I'm not going to try and fudge things up. I don't think I will.
Andrew, you're saying that you won't take the vaccine?
I don't believe I will, no.
Are you considered, because of your transplant, are you considered somebody at risk? Somebody? I am, yeah. So you would, okay, let's put this to a panelist. This is I'm worried for you, Andrew. That's why I'm just want to
totally
please and Andrew's point is very, very legitimate. This is an issue. It's the points that come up time and time again. The speed of the developments of the vaccine and potential side effects. Please, anybody from the panel who could set Andrew Cole's mind at ease here.
I can.
Yeah. Sorry, go on.
Okay, I was just going to briefly address the speed of development. So there are several factors that contributed to the speed of development of these vaccines. Scientists have known about the coronavirus family of viruses since the 1960s, and the first human coronavirus was actually introduced into the population back in 2002, if you remember SARS and MERS. So since that time, researchers at academic institutions mainly were doing research on these developing vaccines against these coronaviruses. And that same knowledge was translated over to the current coronavirus that we have. So it wasn't as though the research was being done from ground zero up. We already had like a large database of research on these types of viruses. Secondly, mRNA technology, it's new largely to the public, but it is not new within the scientific community. mRNA vaccine technology has been used since 2011 to treat cancers with the same vaccine technology. If there was a problem with the technology, we would have definitely seen it before now. And another factor was just the speed of the clinical trials. So normally you have to find people within a specific bracket to enroll in these trials. But because of skyrocketing cases of COVID-19, there was just a very large population of people available for these clinical trials, over 70,000 persons in the Pfizer and Moderna trials combined. So they were able to acquire data on these vaccines and determine its safety and efficacy. And these vaccines went through the same verification procedures that other vaccines have gone through. But because of the pandemic, because of the dire need of the situation, a lot of researchers, governments, companies around the world really worked together very closely, sharing data and also pumping a lot of money into developing these vaccines. So normally in developing vaccines, you focus on phase 1, then you move to phase 2 and phase 3. But what these companies were doing, because they had financial support, they were able to sort of plan things for phase 2 while they were still in phase 1. So everything was ready to go when they got the data. So just to let you know that there was a lot of legwork done before the pandemic happened to develop these vaccines, and speed of development does not mean that safety or ethics around the vaccines were compromised in any way.
Can I
Possible, I can ask a question on the back of that.
So, Tony, just before you get to that, I think just to maybe crystallize what the question, if I can just kindly ask Dr. Phil Bright to just give a quick overview that might answer some of these questions in terms of what are the vaccines and how it's developed and the clinical trials. Is that okay? Okay.
Yeah, I'm happy to go. Some of what I was going to talk about has now been covered, but I'll skip over those bits.
Okay, hopefully you can see these slides. So it's yours, Dr. Bright.
Thank you. Right, so my name's Philip Bright. I'm a physician working in Bristol, and the reason I'm here today is I've done some work on the vaccine trials in the UK. So I'm first going to talk about what are vaccines, and then a few other issues as you've got on the screen there. So what are vaccines? Well, they're substances created to cause an immune response, and they provide protection against a particular infection. They're made by taking a part or the whole of a bug which causes an infection, such as meningitis or polio or COVID, and altering this bug or part of the bug so that it doesn't cause the infection, but does trigger an immune response and gives you protection from the disease in future. For COVID, this involves utilizing a small part on the outside of the COVID virus called the spike protein. This is only a small part of the COVID virus and can't cause an infection. I think it might be better to have me on the screen for now, and we'll come back to the slides later. If that's all right, Oren?
That's okay.
The spike protein is produced in different ways with different vaccines, but the end result is an immune response to this bit of the bug, the spike protein. I'm going to talk about a few case studies of vaccines that have worked previously, and I think the biggest success of vaccination is smallpox, which was removed from the planet by vaccination in 1980. And that's estimated to save about 5 million lives a year. That's one person not dying of smallpox every 6 seconds. I'm going to go through two more modern examples, which are polio and meningitis. So firstly, polio, well, it's an infectious disease that can cause paralysis, and it's almost been eradicated from the world by vaccination, apart from in some regions of Afghanistan and Pakistan. Could you get up the first slide now, please, Oren, for me?
Okay, will do.
So first, I'd like to thank Public Health England, who have published these graphs that I'm going to use in their Green Book. And what this graph shows is the number of cases in England and Wales of polio in the 1940s and 50s. And on the left side, you can see the numbers of cases, and on the bottom, you can see the years as they go by. And with the introduction of the Salk and the Sabin vaccine, you can see the number of cases of polio in the UK drops to pretty much zero, and it's now been eradicated from the UK. And next, I'd like to talk about meningitis, which is something that we probably all heard of now. It's a severe infection that primarily affects children and young people, presents with headache, rash and fever, amongst other symptoms, and kills between 5 and 10% of people that have it. Now, there are different bugs that cause meningitis, but a common one is a bug called meningococcus, of which there are different types as well. Can we get the next slide, please, Oren? Thank you. And I want you to look specifically at the line that looks like a hill, the dark one on the left, that starts at about 1,000, and that's meningitis C. And a vaccine for that was introduced in 1999, and you can see how the cases, this is a similar graph to before, drop very quickly to almost zero following vaccination. So there's 3 examples there of how effective vaccination is in preventing cases of infectious diseases. And in summary, I'd say that vaccination is a safe and a very effective way. It's our strongest tool of reducing infectious disease. And it's estimated that current vaccines save 5 lives every minute. So coming on to my next bit, could perhaps get me again now, because we'll come to that a bit later, talk about vaccine development. So there's understandable concern from many individuals that COVID vaccines have been developed too quickly. And I think that question's been addressed, and all the points that I would make have been made. The thing I'd reiterate there is that there's been practically unlimited funding in creating these studies, and that there were already technologies in place for creating vaccines quickly, which didn't have a particular bug associated to them, that you could then just plug whatever the bug is that's causing a current pandemic into. So that technology was already available and proven, and it was sort of plug and play. And that's one of the reasons why it happened so quickly. I'm going to talk specifically about the 2 vaccines that are commonly available in the UK, which are the Pfizer and the Oxford vaccines. Now, these are made slightly differently, although they're both based on the spike protein, which I mentioned before. Firstly, the Pfizer vaccine, well, it was created with this new technology by putting a small bit of the COVID virus's RNA in a small package. RNA is the code the virus uses for how to make itself and to reproduce. The RNA in this vaccine has only a very small amount of the virus's RNA in it in order to make a small bit of the virus, not the whole virus. It just makes the spike protein. And it cannot cause COVID infection and absolutely cannot alter our DNA. There is no way it can do that. And it only lasts a very small amount of time in our bodies. The small bit of the COVID virus created from this RNA induces an immune response. And we've listed here the ingredients in the Pfizer vaccine, which there aren't that many, but it's got the mRNA, the RNA of the COVID virus, and then a few other things, which are basically the packaging to put it in. It's not a live vaccine, and it's safe to give to almost everybody. And there's no issues with the immune suppression or in those with renal transplant in having it. Now, the Oxford vaccine was made slightly differently. It was produced by putting a little bit of the COVID virus RNA into a virus that causes the common cold in chimpanzees. So this is a common cold virus. It's been altered in such a way that it cannot reproduce, but it's able to produce a little bit of the COVID virus that we want and provoke an immune response. And the ingredients are listed here. Now, I think you need to be a chemist to understand this fully. It's got the COVID RNA inside this modified cold virus, and things to make it stable such that it can be transported without it degrading. And there is a tiny amount of alcohol in there, which is about the same amount that you find in a loaf of bread, and it is considered to be halal. Now, technically, it is a live vaccine, but it can't produce and so cannot cause COVID infection and is safe to use in all patients. So that's a bit about the development. Now I'd like to talk a little bit about the COVID vaccine trials, and I'm going to focus on the Pfizer and the Oxford vaccine trials. The COVID vaccine trials are performed in a very similar way and essentially look at whether or not a COVID vaccine is effective in preventing COVID disease and what the side effects are. So firstly, the Pfizer vaccine. Well, the Pfizer study recruited over 40,000 individuals, mostly from the US, but also some from South America, South Africa, and Europe. And individuals received 2 doses, 21 days apart, of either the Pfizer vaccine or salty water, which is called a placebo, in a 50-50 ratio decided by chance for each individual, just like a coin toss. As I mentioned, they were looking for COVID disease. And what I mean by that is that in order to get diagnosed with COVID in these trials, the individuals had to have some symptoms and then a positive swab for COVID. And the study then compared the numbers of cases of COVID with symptoms between those that were vaccinated and those that received this placebo of salty water. And it was to everyone's surprise just how effective the vaccine was. It prevented 19 in 20 cases of COVID with symptoms in the individuals who received the Pfizer vaccine, and there were no serious safety concerns. Now, you couldn't be part of the study if you had a condition which affected your immune system, but you could if you had a stable medical condition, which may have included some kidney problems or indeed some blood disorders. The Oxford vaccine was very similar to this. The vaccine study was very similar. It recruited a bit under 25,000 participants from the UK, Brazil and South Africa. And they published from a subset of those recruited. And the difference between the Pfizer study and the Oxford vaccine study was that the salty water placebo was replaced with a meningitis vaccine in this to compare the meningitis vaccine to the COVID vaccine. Participants received 2 doses of either the meningitis or the COVID vaccine, and they looked again for COVID with symptoms confirmed on a swab from the throat. And in this study, the COVID vaccine prevented 14 in 20 cases of COVID with symptoms in the individuals who received the COVID vaccine. But importantly, there were no admissions to hospital or deaths in those that received the COVID vaccine. And this looks like this is also happening in the real world. There were no serious safety concerns again. And the exclusions for this were similar to those for the Pfizer vaccine. Patients with some conditions like kidney problems may have been included in the studies, although the numbers of these and what problems that they had have not been published. Now, in terms of side effects, vaccines do stimulate the immune system, so side effects are expected. Mild and may include a sore arm, and actually, I've got a sore arm right now from my second COVID vaccine, which I had a few days ago. The side effects that could be expected are headache, a fever, and feeling tired for a day or two. And what these side effects really show is that the vaccine is working. Severe side effects such as allergic reactions are extremely rare, and these vaccines are safe for almost anyone to take. There are hardly any contraindications. Additionally, I'd say that recent preliminary data has indicated that these vaccines are capable of reducing transmission. This means that getting vaccinated is effective for you in reducing the chance of you getting ill, but also in reducing the chance that you will infect those around you, which is really important in protecting your loved ones and your friends and family. I'd like to talk a little bit about COVID vaccine in Black, Asian and minority ethnic groups. Well, firstly, I'd say that the similarities in the immune systems between people of different ethnicities are much greater than any differences between them. Therefore, you can use data from non-BAME groups and apply this to BAME groups. Now, it's true that recruitment of participants from BAME groups in the studies was relatively low. The recruitment of Black or Asian individuals in the Pfizer vaccine trial was just over 5,000 individuals, and for the Oxford trial, a bit under 2,000. But it was still a significant proportion, and that's about 7,000 individuals in these studies were from Black, Asian or minority ethnic groups. And additional to this, I did a calculation a couple of weeks ago and worked out that over 500,000 BAME individuals in the UK are likely to have now received the COVID vaccine. It'd be more than that now, without any significant safety concerns being raised. Now, it is likely that COVID vaccines won't work quite as well in patients with some blood disorders, blood cancers, and renal patients. But it would be expected that there will be significant benefit in these groups, particularly as they have a particularly high chance of severe COVID disease. And if you're trying to balance the risks of having COVID disease against the risks from the vaccine, it's absolutely on the side of the risks of having COVID are far, far, far higher. The COVID vaccination is safe. So I say to those from BAME groups, and indeed everybody, my friends, family, and myself, that these vaccines are for you, for your family, and for your communities to prevent COVID in you and those around you. Now, if I've got time, Aaron, I'd like to answer a few common questions. I think I should have a few minutes left.
Yeah, go for it.
First of these is one question about which vaccine is best for me. And the answer to that question is a pretty simple one. It's whichever one is offered to you first. The difference in how well these vaccines work, they're not directly comparable, and they're all very effective. So whichever one's offered to you first will give you the protection that is the earliest. There was a common question about why the gap between vaccinations is different in the NHS vaccination programme compared to that used in the trials. Well, that decision was made on 2 grounds. Firstly, to give some immunity to as many people as possible, as quickly as possible. And secondly, it was felt that based on the evidence that delaying the second dose would not reduce the effectiveness of the vaccine and might actually improve it. And that decision has been proven to be right, with proven good protection from the Oxford vaccine up to 3 months with just 1 dose. The second dose then provides, we think, probably for much longer immunity. And it's thought that the principles for the Oxford vaccine will apply to the other ones as well. And there's some evidence to back that up. I think there's a significant worry nowadays whether or not the vaccines are effective against the new variants. And this is a really rapidly evolving situation. And the answer is that these vaccines are very likely to have some effect. The Oxford and Pfizer vaccines are effective against the currently circulating variants in the UK, although there is concern they'll not be as effective against the South Africa variant. And that means it's quite likely that further vaccination will be needed in future with slightly altered vaccines, specifically against the other variants, and work on that is already underway. I've got 2 more common questions which I'd like to address. The first one is it safe to receive the vaccine in pregnancy or in breastfeeding? It's not recommended in general to receive the COVID vaccines in pregnancy unless you are considered at high risk of getting COVID or getting severe disease from COVID. You can receive the vaccine safely if you're breastfeeding, and it's also safe to receive the vaccine if you're intending to get pregnant. And there is a misconception, a fiction, that COVID vaccine can make you infertile, which the origins of this is a theoretical issue raised by an epidemiologist from Germany in a blog, who suggested that the COVID vaccine might create antibodies to a protein on eggs and sperm, but there's no evidence to support that COVID vaccines can cause infertility in men or women. So that is a fiction that has no evidence behind it. So that's not something that should be a significant concern for anyone. Thank you. That completes what I wanted to say today. I'm happy to answer questions later. Thank you, Orin.
Thank you very much, Dr. Phil, and really appreciate that overall analysis of the vaccine and its development right now.
Orin, can I just say, can we have Dr. Phil Bright on the government briefings, and about, you know, every day they have the daily government briefings. Can Dr. Phil Bright just forget Chris Whitty, forget Patrick Vallance, please let's have Dr. Phil Bright. That is one of the most concise and informative explanations of vaccines and the COVID vaccine. That was incredible. I need to post all of this up as soon as we finish this. Anyway, sorry, go ahead.
Claudia, I was going to say that at this point, should we bring in Tony Cox, who is not convinced by the vaccines, and maybe if we can get some of his view on this, then we can put that spin on it as well.
And to the other panelists as well.
And for the panelists, just to be able to answer some of Tony's concerns.
Yeah, which is basically on behalf of what Andrew Cole sort of started in terms of the questions he had, which Dr. Phil highlighted and answered, but there's still doubt. Tony.
Hi, yeah, well, thank you very much for inviting me, guys. I'm going to cut straight to the chase. Dr. Phil Bright, thank you very much for your description of the various vaccines. My issue with what yourself and the other learned doctor have given is that you've summarized the work of all the various manufacturers of vaccines into a nice, very presentable package, which sounds very impressive. Unfortunately, I don't look at it that way, because there have been a very large number. I think at the outset, over 150 different vaccines were put into production for trial. And to date, we now have, I believe, 4 different vaccines which have been authorized in different ways. Now, in relation to what you mentioned, in relation to recruitment of trialists, you very nicely put in that 5,000 were from the BAME community from one test, and 2,000 were from the BAME community on another test, which is only 7,000. But what you fail to realize is, as a Black person, we don't appreciate that BAME grouping. because I am not Chinese. As a black man, I don't recognize when you say I'm going to group Chinese people, Indian people, African people, Caribbean people, and any other ethnicity in the same group. Why is it that white people are put outside of that group and black people and Asian people, who have got much more complex DNA into the same hat? As Oren and Bev will validate, you can find a bone marrow match in 1 in 5 white people. For black people, that ranges from 1 in 500,000 or more. So why am I suddenly being categorized as BAME? It doesn't help me gain any confidence.
Tony, that's a very good point. Dr. Bright, and indeed you're saying Black, Asian and minority ethnic groups, and you had 5,000 from both those trials, the Oxford, AstraZeneca and the Pfizer trial, but that still doesn't break it down to each specific group, Asians, African and Caribbean. Can you explain that, and is that enough to reassure people from all of those communities, really?
Okay, yeah, I'm very happy to respond to that. So yes, a very valid point to say that being grouped is not helpful for you. I would say that there are significant numbers of Black individuals involved in these studies. Whether or not it's 7,000 or whether or not it's 2,000, I don't think helps very much. It has been given to significant numbers of Black people. I don't know the exact numbers off the top of my head, but you're probably talking about something in the region of 2,000 in the studies. But the important thing to me actually isn't the studies. It's the fact that when it's been rolled out in the UK and in lots of other countries, this has been given to a very, very large number of Black individuals. And there have not been significant safety concerns raised in those rollouts. So in the UK, I don't know the exact numbers of Black individuals as a percentage of the population, but we're talking something in the region of 100, 200,000 individuals from the Black ethnic groups who have received received a COVID vaccine without significant safety concerns being raised.
Can I, at this point, take it even further in terms of the questions that Tony's asked in terms of identity and how we are grouped in certain ways? Take it to another stage, and just to highlight, especially for those who are watching, just how far deep the hesitancy goes and historically where it's come from, which will hopefully fuel even more debate going forward with the rest of the panel to interject, and patients like Chanel and Vanessa. I'm going to show a slide which Tony is very familiar with, and other people who are watching are very familiar with the facts. It's a slide which hopefully you can see, which highlights the concerns. And you'll see on screen, there's historical things which have been done to Black people. And we don't apologize for showing it and highlighting it in our work, core work of stem cell blood and organ donation. We constantly are referring to Tuskegee syphilis, Henrietta Lacks her stolen cancer cells, the Codrington slave breeding experimentation during slavery, Namibia's Shark Island genocide at the beginning of the 20th century, which was the trial run for what the Nazis did to the Jews, and so on and so on, as you can see on that screen. These are where the doubts are being triggered. And we know these facts are facts, they happened, but now we need to go forward. As we've always said in our work, it's up to us to actually try and make a difference to help ourselves, because it comes to racial matching for the work we do. Now we're taking it to the vaccine level to help not only ourselves, but to help humanity. And it's really a case of just getting to these sort of questions that need to be answered. And hopefully some of the questions that I'm going to show on screen, which will hopefully fuel this debate in terms of the impact of COVID. And you talk about race, Tony, and others are thinking and typing about this. Is there if there's any difference in outcomes for people from Black, Asian and minority ethnic groups? Vitamin D and herbs, even why some doctors are against the vaccine and so on. You can see some of the questions that are on the screen. This is what we need to try and get to the bottom of. And race and identity does come into it, as Tony and others are alluding to. So
can we do some quick short fire answers for some of the
yeah, let me take this off screen and see if we can
Orin, can I just put something out there to the panelists, just off the back of something Tony said. Do Black people have a more complex DNA compared to white people? Any doctor out there, Dr. Uwadia?
I don't actually know the answer to that and whether or not we have a more complex genetic. What I do know is that the genetics between Black people or white people or people from any other ethnic group, they're more similar than they are different. So if you got a group of Black people and you got a group of white people, or people from India, for example, they wouldn't necessarily group together based on their race and melanin. Because I think sometimes when people see that, they presume that the Black people will be more similar genetically and the white people will be more similar genetically. But actually you'll find that it'll be an array amongst all of that. So I think just to take the vaccine and just say, you know, because of our genetics, it's unlikely to work in one group over another, doesn't make sense to me. I think there might be some small differences that happen, but we'll find out over time, and that won't necessarily be related to the color of your skin. That's my general feeling on that point.
If that was the case, why is it that when you're looking for a match for leukemia, you can find 1 in 5 for a white person, but it's 1 in 5 in a million for a Black person? It's too simplistic.
Dr. Price, I think that's something
very simplistic.
Sure, Tony. Let's bring in Dr. Price. I think she's someone who could just answer that question.
I think Tony raises a very good point there. I would echo what's just been said, that as a race, we are much more similar than we are dissimilar. So a lot of the inequalities that we see are not because of biological factors, they're because of structural racism and patterns that existed over a long period of time. The comment that Tony made about finding a match is a really important one, and I come from a transplant background. So what we do is, for patients who have particularly high-risk malignancies, leukemia, lymphoma, and also other non-malignant hematological disorders like sickle cell, transplant offers a curative approach. So it is a real problem when we trying to find matches for people from the Black community. Now, the reason for this is that even though the vast majority of our DNA is exactly the same, there are some what we call polymorphisms. This means slightly minor differences, and we know that in certain Black populations, also in some other ethnicities as well, they have a higher degree of variation. So when you're trying to look for an exact match, it's harder to find that 10 out of 10 match. So you're more likely as a Black person to have a unique phenotype, as we call it. So fortunately, the data is a little bit better now, but if you look at someone who's from a Caucasian background, if they were trying to find a stem cell match, they would have about a 70% chance of getting a full match. If you're from a Black community, I think Black with South American heritage is probably the most difficult. We're looking around a 20 to 40% chance of finding that full match. So yeah, that's due to those polymorphisms. So those that on our tissue typing, which is the markers on all of our cells, there being a greater variation amongst certain populations. But I would stress that we are more, we're largely a very homogenous. That means like we're very similar in all of our DNA and our makeup. It's this sort of genetic variation which tends to be geographically distributed depending on your ancestry. There's no gene for being the color of your skin.
But also with that, I would say that another problem, the bigger problem, Tony, is that not enough of us register as donors. That's so, which makes it even harder, which brings it back to why ACLT was started. So, but we don't want to kind of come away from the subject matter. And that's the really important.
And I'm hoping to bring this back to Mr. Andrew Cole. From what you've heard, Andrew, so far in the presentation and the discussion, is it assisting, or is it even creating more doubt, or how do you feel about this?
Not really, because it's a prevention. It's not a cure.
Okay.
Yeah, and that's the way I look at it. It's just like I take my medication every day. What is it? It's a prevention. Yeah, it's not a cure, and I live with that. You know, so subconsciously, I know where I'm at. I know possibilities of what can happen and what can't happen, and I'm more than happy to live with it. I've got to be brutally honest. I'm going to live with it. You know, I can't lie. I'm sitting there and I'm listening to all the possibilities of this, the possibilities of that. That's how I live anyway.
Okay.
So what difference is it going to make if I take the virus? I mean, if I take the vaccination, what difference does it? It doesn't say to me, right, you are not going to get it. Yeah, and if you do take the vaccine and you do get it, what gives me opportunity to say I'm going to survive it anyway?
Keep that thought there, Andrew. I want to bring in Chanel and Vanessa as other patients from a blood cancer, leukemia, and also from a sickle cell blood disorder situation. What are your views, ladies?
I wanted to actually piggyback off what Andrew was saying and kind of tie in what Dr. Phil and Anthony Cox was saying, because as a sickle cell patient and a blood recipient, I think what you need to understand is I'm always fighting my life every single day. So having treatment and what best treatment is for me, you have to be vocal in it. Dr. Phil Bright mentioned that if you are given the vaccine, the choice of the Pfizer or the Oxford, you know, you don't get a choice. I want to have a choice in what vaccine that I take, because I have a choice in the treatment that I take long term. Sickle cell and having, you know, regular blood transfusions, that's long-term care, that's long-term treatment that I have to discuss and be vocal with my healthcare professionals. Now, Anthony mentioned that there was 4 vaccines. I was only aware of 3. Why is there only 4? Why are there 4 vaccines? Where it's only accessible to other people? I want to have a choice in a vaccine if I do decide to take the vaccine. And Andrew said it really, really well. It's prevention, not a cure. People with sickle cell, they've been waiting for a cure for all their lives. So what's there to say that, you know, the vaccine is just a preventative measure? So my concerns are, you know, why don't I have a choice in the vaccine if I'm going to be offered the vaccine? And why are there 4 vaccines that is only accessible to, you know, certain people? You know, there's so much that goes through my mind. Those are my concerns.
So can I just ask? Sorry, Claudia. Isn't it a case of that if you have the vaccine and you get the virus, that the virus is much depleted, and so the effects are not as bad as if you didn't have the virus?
Yeah,
the vaccine.
Let's put it to one of our medical professionals. I know you were putting it to Dr. Bright, so I don't know if you want to go to Dr. Bright, or anybody who wants to come forward and just really give their response here.
Dr. Ngasa?
Sorry, I was planning to intervene to make comments regarding Andy's worries. Can I start with that?
Yep.
Yes, absolutely.
Yes, please.
So, Andy, I work at the Manchester Royal Infirmary, where you had a transplant. It's one of the centers which do the highest number of transplants in the UK, over 300 transplants a year. I run transplant clinics 2 to 3 times a week. And I can assure you that we were bombarded with calls from our patients, whether they should take the vaccine or not. Most of our patients had the vaccines, and I can assure you that we've had no cases of organ rejection as a result of taking the vaccine. We haven't had any cases of interaction with anti-rejection treatment. We haven't needed to stop anti-rejection treatment due to the vaccine. So, as you must know, as a patient on immunosuppression, you run a higher risk of developing severe COVID-related disease. And the main aim of the vaccine is to prevent this. So putting on a balance, I think it's more of a benefit having the vaccine as a transplant patient, because at the long run, we want to avoid the severe disease. So I've got a question for you, Andy. Do you take the anti-pneumococcal vaccine and the anti-flu vaccine, which we advise our transplant patients to do? And have you ever had any serious adverse reactions from them?
I don't take any of them.
Okay.
No.
Hold on, he was gonna.
Sorry, can I just come in here quickly?
Yes, I was going to bring in Terence.
Yeah, I'd just like to, there's 2 points, Anthony and Andrew. I mean, Anthony, first I'd like to say this, Anthony, as a black man, and this is going to go back to Andrew as well, as a black man, I 100% understand the concerns of our community when it comes to structural racism in healthcare. From cradle to grave, the statistics are stark. And I'm not going to sit here and pretend that stillbirths are twice, black stillbirths for black babies, twice the rate of whites, life expectancy for me and you cut by 4 years, from cradle to grave. The statistics are stark. Maternal care, 5 times more likely as a black pregnant woman to die in childbirth. We are not going to nice it up and dress it up and say, actually, we'll sweep this under the carpet, because we need to tackle these issues head on. And so I come here today to say, look, one, I'm aware of it. I'm aware of the racism in healthcare. I'm aware of the infamous history which we have in America and coming to the UK, and the fact that black people are considered to have higher pain thresholds than white people, even in the medical profession that's considered. And the fact that as a medical student, the people that are tested for things like meningitis when you're doing studies, they've had to be pulled up on the fact that you need to introduce black skin into these things. So I'm 100% with you, but I'm going to say this, I'm taking the vaccine. And the reason why I'm taking the vaccine is because I personally have weighed it up and I've decided that when I've looked at the risks of contracting COVID-19 and the risks associated with the vaccine, it's come down quite clearly in favor of the vaccine for me. And that's why I wanted to say to Andrew, look, Andrew, man, you've got a condition. Having had a transplant, you're a vulnerable individual. You're still relatively young. And I'm wondering, given the weighing up exercise, and given what I know, and given what you know about racism in healthcare, is it not the time that we say, well, actually, let's spot the wood from the trees? What is racist and what isn't? In my opinion, and I say this quite categorically, in my opinion, I do not believe vaccination, COVID-19 vaccination, is harmful for black people. There are naturally going to be, with all medical treatment, there's no such thing as 100% safety. Impossible. All medical treatment comes with acceptable risks, and there are acceptable risks with this vaccine. So that's my opinion. If your misgivings are to do with yourself as a black man in this country, where we know there are serious inequalities, then I say to you, look, I'm a black man too. And I've come to the conclusion that this vaccine is not to do black people harm.
Okay.
Andrew, would you like to reply? So what Terence is saying, look, statistically speaking, taking the vaccine versus getting COVID statistically could bring you more harm, Andrew, than taking the vaccine. Yeah, your response to Terence.
I totally understand that. I'm not going to sit and say I don't totally understand that. Yeah, but right about now, I honestly don't believe it's the right decision for me to make. You know, and I'm being brutally honest. I can't lie to myself. As far as I'm concerned, I've been living like this for the last 6 years. At any stage, I could have picked up anything in those 6 years and passed away. So for me personally, for me to take a vaccine, yeah, that is another prevention, ain't gonna give me a cure. Yeah, I'm looking at it now and saying to myself, what difference does it make? Really, what difference does it make? It doesn't guarantee me anything. That's the way I look at it. And everyone, we're all entitled to our own opinions. That's why we're having this debate. You know, but for me, right about now, I don't think it's the right thing for me to do.
Andrew, could I just ask you a very direct question, and then we'll go straight into Chanel and Vanessa and Dr. Eve. I just want to ask, if you had not had a kidney transplant and none of this had happened, would you be in the same place?
I'll be honest, I don't even know, because I think sitting down and looking at things logically, you know, what's being said, good, bad, or indifferent. You know, I've never been an individual who's wanted to take vaccines anyway, or take pills or whatever it is. You know, so now this has come about, it's like, come on, man, how bad can things get?
Right.
No, but like I said, everyone's perception is totally different.
Yeah.
Totally appreciate it. Before I bring in Vanessa and Reverend Eve, I just want to hear, because we were talking about the risk, and we talked about what the vaccine and the pros and cons, but I just want to hear from Dr. Hussefa Ademali, what you're seeing in the ICUs, just to paint that picture in a couple of minutes of the other side of the coin.
And can you tell everybody what your day job is, Hussefa?
Oh, thank you. Thank you, Aaron. So my name is Hussefa Ademali. I'm a respiratory consultant at Southmead Hospital. I work with Phil Bright. Phil is the immunologist, I'm the respiratory consultant. So I work as a pulmonologist So I, for the past year, have been dealing with COVID-19 day in, day out. It's tough, folks. One of the things I just want to reassure our audience that majority of people who develop COVID-19 will recover. However, in the vulnerable group, you are high risk of developing COVID-19. So you're likely to come in difficulties, and it'll be when you pick up the phone to NHS 111 and say to them that, listen, I feel really short of breath. I feel I can't get more air into my lungs. It's when alarm bells will ring and you will probably have to present into your hospital. And that will mean going to a medical assessment unit or going into emergency department. It's frightening for people from our background to enter a hospital setting because we're not accustomed, majority of us are not accustomed to going in hospitals. And it's the young that arrive to the hospital quite bewildered. Not only can they put sentences together, but that enormous air hunger. They will also have temperature spikes and they feel extremely exhausted. Fatigue is a big problem. So when you arrive, they will put you on oxygen and they will observe you and they will monitor your oxygen levels, your temperature. They'll give you your blood pressure, your pulse rate, and they will monitor you. So you'll meet a doctor like myself who will arrive and will say, right, we'll have to confirm COVID, which they will do a swab. They will start getting a chest x-rays, imaging, bloods, and eventually they'll see that your oxygen levels demand are going up and up and up. And it is eventually the penny drops that you can't tolerate the 1 to 2 liters of oxygen. You may have to go on a face mask and eventually on high flow oxygen. And that is troubling for us to view patients deteriorate in front of our eyes, despite giving them dexamethasone, which the recovery trial has shown to benefit, despite giving them remdesivir, which is the antiviral medication that has been seen to shorten your stay within the hospital setting. And eventually, these people, majority of people will respond, but some of them will go and have increased oxygen needs. And eventually, you will be on high pressure, high flow oxygen. It's troubling, folks. You are there on your own with physicians and nurses. You don't have access to your families. They might get a priest in to come and talk to you or a psychologist to come and help, but you're pretty much on your own. Eventually, if your oxygen requirements go up and up, you may need to see an intensivist. That is that's a doctor who deals with patients in an intensive care unit. And they will come and talk to you about intubation, that's putting a tube down your throat and putting you on mechanical ventilation. And we see that approximately 5% of our patients will end, 5 to 6% of our patients will end up in an intensive care unit. And that is when you are sedated, you're on a mechanical ventilation. Now they're really trying the utmost to ensure stability and prevent deterioration. Your lungs become almost like filled with pus, infection, and it's very difficult to ventilate people. And eventually, after 1 to 2 weeks, some of the patients will recover. We have a recovery of approximately 55% in our ICU. We'll get out of ICU, we'll get off the mechanical ventilation, but 46% of our patients will pass away.
So,
now, I'm sorry, I really care. Like all these people in this, I've seen not only whites, but blacks, Asians. And before we ventilate these patients, you look into their eyes and you look at the fear. They're frightened and they don't want to die. Those emotions are really hard to fathom. And for all the people who are present, it's incredibly difficult for us physicians to see our patients in that difficulty. So going back to Andrew, I can completely empathize about your fears of the vaccination. But for the past year, we have seen so many deaths in front of our eyes. It's heartbreaking. These are our loved ones, our brothers, our sisters, our mothers, our fathers, our grandparents just pass away in front of our eyes. I just want to leave you with one thought. I was in a HDU, a high dependency unit. I had 3 patients on these face masks, and unfortunately, these patients were not going to go to ICU. Within a matter of an hour and a half, I was running from one patient to another patient, trying to support. They passed away. And it was so difficult for us and the nurses. Which hand do we hold? Which person do we support? And it wasn't funny for us at that point in time, because I was reflecting, where in the patient's journey did we go wrong? Was it because we did not give the information to the patient that it was imperative for them to self-isolate? Didn't we give the information to their loved ones that it was important for them not to bring the virus to their elderly parent? Or was it at the time that I don't want to be in the situation that one of us did not get the vaccine and we compromise not only ourselves, but our loved ones around us? We really have to reflect. You as an individual are very important to us. You as an individual are important to your family member. You as an individual are important to this community. And as a result, I, as an Asian doctor, part of the Black, Asian, minority ethnic, would truly advocate the use of vaccinations. It makes sense. And we have given millions now, and people have tolerated it well. Thanks, Oren.
Thank you so much. Before I hand back to you, Claudia, I just want to quickly hear from our last patient rep, Vanessa. Quick view of how you feel about what you've seen and heard so far today.
Hi, Owen. Thank you. Wow, what Dr. Adamali just said was actually quite frightening. Listening to your description was actually quite frightening. When I came on today, I had quite a few things I wanted to ask, but a lot of it has been addressed somewhat. I wanted to know more about clinical trials and if people like me were represented in those trials. Now, I was diagnosed with leukemia 5 years ago. I am fortunately in remission. I was somebody that was told I needed a stem cell and one has never been found for me. So I've had to live my life, just really going about my life as I have done without a stem cell transplant. But I am in remission. So I also wanted to know, I was going to ask, how many patients with leukemia or that have had chemotherapy were part of the trial? And I can see that there is not going to be a definitive answer about that either. I've spoken to my own consultant about this, and she said there isn't enough data. So that concerns me as well. However, and I will say, from my understanding, and I'm not a medic, one of the things I've suffered with is having a compromised immune system. So my neutrophils are always low. So at the moment, I live with my daily neutrophils at about 1.2, which is, maybe one of the other doctors could explain that better, but it's about my risk of infection and germs. So mine is quite low. I'm now living with it at 1.2. When it used to be below 1, I was always admitted into hospital. Since I've been in remission, it's been stable at about 1.2. My consultants have said to me, I believe a normal neutrophil is above 4. So my question was, well, how am I managing to live without being in hospital anymore with mine at 1.2? What should mine be if I was healthy? And she said, to be fair, as a Black person, they were not able to say because there is not enough data. So she said to me, my neutrophil level could be normal at 1.2, but because there's not enough Black people that were ever tested or checked, there isn't enough data, they don't know. So where we have these conversations about, I'm just saying, Black people and white people being the same, it's not true. Not all aspects of it are true because there was no data to help me. Having said that, I'm due to take the test on next week, Monday. So I really wanted to be here to listen to what was being said. And if I'm honest, I think that I'm going to probably have the test on Monday. But what I'm hoping from me having the test, my data will now be in the system.
Sorry, so, Vanessa, do you mean you're having the vaccine on Monday?
Yes, I'm having the vaccine.
I just wanted to verify, sure.
Yeah, thank you. So I'm probably going to have the vaccine on Monday. And what I'm hoping then is that my details will be in the system, but I'm only one person, but it will be in the system so that when they are looking for data from Black people, from Black females, from leukemia patients, from people who have had chemotherapy, there will be some comparison or some data that they can use.
Thank you so much. Claudia?
Thank you, Vanessa.
Yeah, Dr. Price, I see you want to come in there. Anthony, I'll come to you in a moment, but Dr. Price, I'm sorry, do go ahead.
Yeah, I was just going to reply to Vanessa about some of her queries coming from a haematology background. First of all, I'm really pleased that she's in remission, and that's great news. And it sounds like everything's going well. So what I would say from that is she raises a very important point about certain groups not necessarily being as represented on the trials. Of those are those who have been immunocompromised, of which leukemia patients, lymphoma patients are included. I think for the Pfizer vaccine trials, I think there was about 70, 80 patients with a background of leukemia and lymphoma who were on the trial. But generally speaking, those who were immunocompromised weren't included. And that's really important because obviously we know that people who are immunocompromised are increased risk of severe COVID. And certainly from a haematology perspective, we were very alarmed by the fact that a lot of patients who have leukemia, lymphoma are transplant patients, also are non-malignant patients like aplastic anemia, sickle cell. We were seeing that they were more likely to get severe COVID, and that's a huge worry. So getting vaccinated in that group is a real priority for the haematology community to protect the vulnerable patients. The question particularly about being immunocompromised is for the vaccine to work, you need your immune system to kick into gear to make those antibodies. And the concern is that if someone's really immunocompromised, perhaps they won't mount as decent an antibody response. But we know from looking at transplant patients historically, who are often immunocompromised for a very great amount of time, a year post-transplant, we start the vaccination program for revaccinating for things like Pneumovax, which is the pneumonia vaccine, and for other vaccinations as well. We normally start that about 3 to 6 months after the transplant. So even in people who are immunocompromised, we want them to to have the vaccine because we do sponsors. So for leukemia lymphoma patients, we're very keen for them to get the vaccine. Because a number of reasons. One, we don't want them to have severe COVID. Also, we don't want them to have any interruptions to their treatment. So if they are having chemotherapy and then they have COVID and then it's delayed, that could potentially be really harmful. So I think that's really important. The other point Vanessa made really importantly is about representation and data. And I think that is such a really, really important point, because we need to make sure that we have the data that represents our population. So we need to have data on Black patient experience. And, you know, historically, there's been a lot of discriminatory research, and that is a huge problem, because that has obviously meant that members of the Black community have a level of distrust because there's been some absolutely appalling practices in the past. So you can understand why there is this level of like, well, you know, who is this serving? But trials are really, really important for advancing medical care. And that's why it's so important that it's a representative, it's our population as a whole, and that everybody can see themselves reflected in that data. So that's a really, really important point. And what Vanessa was saying about that, I think is a really take-home point, that we should be collecting this data and we should be, you know, validating that. What you meant about the neutrophils is also just to come back to that. So neutrophils are one of our white cells. They're very important in mounting an immune response when you've got an underlying cancer disorder. Sometimes you can become neutropenic, which means your neutrophils are less than 1. Normal is about over 1.5. That makes you a bit more vulnerable to mounting and a response to infection when you first get exposed to bacteria, because neutrophils are very good at basically eating, chomping up the bacteria. So it makes you very vulnerable to infection. There is definitely just differences in certain groups, and we know that in Black populations, they tend to have a slightly lower neutrophil count. It's something that we've termed ethnic neutropenia, which is probably not a very helpful term, but we do see that. But again, as Vanessa said, the more we have of more data we have, then the more we can make it truly representative to you know, your specific situation.
Thank you. Claudia, just before I hand back to you, I just want to, two things. I just want to highlight, say, massive thank you to Dr. Linda Bello, Dr. Valentine Ngwa, and Dr. John Ayug. They're not saying anything because they are busy answering all your questions in real time. So if you're wondering why you're not hearing from them, they're actually very much busy answering all the questions that are coming online. We really do thank you for that. And the last thing I want to bring in, before Claudia, you bring in people like Dr. Asher Williams and Dr. Ngasa and of course Mr. Tony Cox for discussions. Faith is very much a key element of this, especially for the Black community. And I think we need to hear from Reverend Eve Pitts in Birmingham, her personal view on this whole debate about the vaccines.
Thank you, thank you. In my capacity as parish priest in Birmingham, I have the privilege of meeting people daily. Only this morning, met 3 people in the park while I exercised. And one of the recurring conversations we have is, I have a faith in God, so why do I need to take the vaccine? And it's a legitimate question. I mean, my job here is not to dismiss that kind of question and to minimize it. I think firstly, as a society, we need to acknowledge the medical profession, our education system. We all know of the inequalities that's inbuilt in the system. And therefore, I understand how this can really stop people from trusting. So I'm not here to defend the system. I'm here to say the people I meet in the street, we're a deeply spiritual people. One of the great things about Black people is that we're deeply spiritual. And the woman said to me this morning, she said, well, Reverend Eve, she said, if I take the vaccine, that's going to mean I don't have any faith in God. And it's an astonishing question, because more people believe that than I thought. A lot of people, men and women over the months, elderly especially, who have a profound faith in God, clear understanding of God's love for them, but somehow cannot bring themselves to take the vaccine, partly because of all those distrust that we've had, for good reason. I think for me, after we've come through this period, we have to meet again in a way that with government officials to tackle the deep distrust. We can't just say, yes, there's distrust and not attend to the needs. At a spiritual level, we, the spiritual people that we are, I want to assure those I meet, I respect their passion, their faith, and sometimes wish I had the kind of faith that the people I encounter have. But it is not a denial of God's love. It is not a denial of belief in God that you decide to take the vaccine. In fact, one of the great things about human history is the development of medicine and science. And I'm not a scientist, clearly, but I think we need to have a discussion with scientists about who are Christians to talk about the silly distinction between believing in God and science. And God and science, to me, can go together. So fundamentally, my job here is to say to the people I meet, especially young Black men, it is sad because I know many of them have lost loved ones. I have taken services myself. I have lost friends of mine, school friends, only today from Nottingham, a strong Christian man. And his girlfriend said to me, how could this be? You know, he has a strong faith in God. He's cared for himself. And so I try very hard not to inflict guilt on anyone about the fact that they may decide not to take the vaccine. My job is not to do that, but to say, nor is it a denial of faith. The two can go together. So I implore those I meet daily, and I do meet them daily, and some of them have loved ones who are still in hospital, to say your faith in God, the God who says he loves us. Fundamental thing about God is that God's love for us as a people and as his children, all of us. And to say that this love is not dependent on you being blind obedient. Blind obedience to God does not honor God. What honors God is that we say there are men and women in our society, Black nurses, Black politicians, Black scientists, who have helped to develop this vaccine. I know certainly in America. And it's for us to say, yes, we know what's been done. We know that as a spiritual people, we have been very trusting. And I'm not saying we should get rid of that trust. What I am saying, however, is that let us understand, I don't want to see any more of my friends. I don't want to hear, somebody said, one of the things, I did one funeral today, one yesterday. One was directly to do with COVID. And a young man said to me, he said, Reverend Eve, I can't take it anymore. I can't say goodbye to another friend. I don't want to say goodbye to another aunt and another uncle. And I don't know what to do. I don't know how to persuade them to take this. And I said, the best thing is to, first of all, not to let them feel silly, but to say, and it was a very faithful congregation. They were singing Amazing Grace and all the stuff that we love. It is not a denial of God's love for us. It is not turning our backs on God. It is a complex world in which we live. And I trust and hope that my place on this committee this evening is to say to those people I love, those I don't know, the people from whom I have come and descended and continue to be part of, is that our faith, our tremendous faith, is not a denial when we say yes to medicine and to science. Yes, it's been used against us. I hope the government will address that. History must be addressed. Unless we address, we can't simply sweep it under the carpet. But for the moment, let's park it on one side and deal with the reality of our community. And I see it in my work as a priest. I speak to young people who've lost their grandmothers, uncles. Only today, an uncle who was unwell, was expected to live, and now he's being grieved for. Science, Christianity, and faith can be in the same place for us to talk about when we've come through this pandemic.
Thank you.
Reverend Pitts, can I ask, you've taken the vaccine. Would you be okay in talking about the reaction that you've had to that?
I mean, when I rather naively, a few weeks ago, I released a video to my congregation to say that I had to really think this through and my own struggles. But I know I have grandchildren, and I have my children whom I love dearly, like everybody else. I want to live long enough to be around them. And there's been some people who've said I should have not said anything. But I have a responsibility as a minister to my congregation, and to say this is my position. And I was very careful not to say this is what you must do or must not do. I'm very, very careful about that, or to allow people to feel, to encourage people to feel silly because they've said no. I've taken it. I took mine last week, and I did brace myself for the criticism, but equally I have lots of people who come, they've been in touch on my phone, I've met them in the park or in the streets or on the bus, and they've thanked me for my input. And I don't do it because, I do it because I love my people. It's as simple as that. They're people of faith, and I love them, and I see the suffering firsthand. As a minister, I see what it does. It decimates family. And all I can say is I do it with the best of intentions, and I hope that whilst I will not force anyone to agree with me, is to say, for goodness sake, please listen and see if we can. We've suffered enough. There are people who've been through terrible suffering. Our history has been littered with pain, but let's not suffer needlessly. For the moment, let's deal with this. Then we can deal with some of the things that must be addressed, the inequalities within the system.
Anthony, if you give me a moment, I will be coming back to you. I can see you've got a lot to say. There's a lot of reaction you want to have. We've been hearing a lot. I just really want to go back to Chanel. She made a very valid comment and question over the choice people can have, particularly if you do have underlying issues, over the type of vaccine people can take. And she sort of disputed what we know, what is out there in terms of the number of vaccines. If I could put it to Dr. Bright, if you can just explain, why is it people can't have a choice, and indeed the number of vaccines that are available right now.
Yeah, absolutely. So it's a very valid question. There is not evidence, strong evidence, to say which is better for any particular group. The protection against disease at all seems to be higher with the Pfizer vaccine compared to the Oxford vaccine, but the protection from hospitalization and death seems to be higher for the Oxford vaccine. So, and when you're trading these two, they are both highly effective vaccines. So I understand people's wish to have a choice. There isn't evidence at the moment to say that one is better than another. And there's also a reason of equity. The availability of vaccines is limited. We have a lot more of the Oxford vaccine than the Pfizer vaccine available. And therefore, if you give people choice, then it will be difficult to decide who gets which. I think if there is evidence to say that one is better than another and the availability of that vaccine, at that point, the decision will be made to offer that particular vaccine to that particular group. But at the moment, there isn't evidence to back that up with. So I think that's the justification behind it. I do fully understand people's wish to have a choice, but at the moment, the government have decided that that's not the case.
And briefly, if you can, Dr. Bright, in terms of the vaccines available right now, isn't it 2 vaccines, or do you confirm how many vaccines are available?
There are 3 vaccines that have been approved, of which only 2 are currently available. So the Moderna vaccine has been ordered, but we don't have any of it yet, and it has been approved. So the 2 available for use at the moment are the Pfizer and Oxford vaccines. There will be other ones that come along because there are so many in the pipeline. I've been working on the Janssen vaccine, which does show good efficacy, and even with 1 dose. And there are trials ongoing with that. There will be others that come along, and the ones we have already will be changed a bit with new variants.
Okay, Anthony. Oh no, sorry, go on, Oren.
Just before we bring Anthony in, because Anthony's going to speak next, I just want to make sure that it might be in response to what Tony Cox is going to say, but Dr. Williams and Dr. Udese and Dr. Ngaza, be primed to respond to, I think, what Tony's going to ask. So Tony, up to you.
Indeed. So with Tony's questions, whoever would like to respond, just get out there and say, Tony, over to you.
Hi guys. So once again, it's been interesting listening to everybody and their different views on all the different matters of this vaccine. But the one thing that seems to be prevalent amongst the entire group, and particularly with Terence and Eve, is just listen to me, just believe me, I'm taking the vaccine. It doesn't work that way. I need to be, as a educated human being, presented with data which supports an argument to validate why I should take a product. Yeah? Now, I know in the past, we take flu vaccines and we never ask the questions. We take vaccines to go on holiday and we never ask the questions. But unfortunately, we're no longer in that space. We're in the information age. And what we're seeing is the reluctance to deal with questions which people have in relation to the quality of products which we're receiving. So we're not being told that there are several different vaccines in production. We're not being told that actually you should be given a choice, because the way the vaccines work are all different. You can't put all those vaccines into one hat and say they're all the same thing, because they're not. They work differently. Yeah. What you're also talking about, and this is something that Dr. Price mentioned, immune system. I don't hear none of you talking about what should you do to improve your immune system to stop the contraction of the virus. Yeah, we've got studies being touted all over the place about the validity of vitamin D, yeah, and how that can stop you getting COVID in the first place. But nobody is addressing that issue.
Tony, let them come back and answer.
Okay, all right. So if you're looking for
hydrochloroquine,
sure, Tony,
hydrochloroquine was touted as something that was ridiculous by Donald Trump. Yet nobody's talking about these products, and I know.
Sure. Okay. So let's bring in. Let's start dealing with your concerns one by one in terms of your immunity issues. Dr. Uwadia, who is a immunologist, please feel free to deal with that query in terms of why people haven't been speaking about the ways we can better protect ourselves, particularly those in the Black and Asian community.
Yeah. So I thought I'd actually start off with you were talking about the different vaccines and how they're getting there, and they're all working at the moment to target the spike protein, which is on the surface of the virus, and how they do that is different, but the end result is that you mount an immune response against the spike protein that your body then reacts to. You produce lots of antibody, and then you can basically get protection. So although they're using different means to get there, they're all basically working to get to the same point where you can be protected. In terms of vitamin D, for example, so there have been quite a lot of studies in the past where people have talked about vitamin D and your immune system and the benefits that it has towards your immune system. But I think for one thing, although there are a lot of studies, no one knows about vitamin D as a preventative measure in terms of COVID, for example. So while it is good, obviously, don't get me wrong, it's just at the moment, the best way forward, as far as I'm concerned, is the vaccine. It's proven, it's been through clinical trials, but we haven't got clinical trials, for example, comparing vitamin D supplementation in the case of COVID-19, for example. And furthermore, while...
Or is that just because you want to exclude those trials? Because those trials exist and the data exists. But for some reason, everybody I hear talking about vaccine always excludes those studies. And I don't understand why.
As far as I'm aware, I haven't seen any studies talking about vitamin D as a...
Tony, let them finish. Let them finish.
Okay. I haven't seen any studies of vitamin D in comparison as a preventative measure for COVID-19, so SARS-CoV-2 virus. But what we do know is that if you take the vaccine, that you can prevent severe disease and potentially also reduce your risk of transmission. So that's where we are at the moment. If anyone else wants to add anything.
Can I just jump in on that?
Yes, Dr. Williams, a very person.
Yeah, so first you have to understand what causes the disease. It's a virus. Viruses are these very, very tiny organisms They've been around for hundreds of years, and they've learned over that time how to very efficiently evade our immune systems and also to transmit and replicate within our systems. So things like natural remedies, vitamins, all of those things are really good for boosting your immune system. But when it comes to a virus, you need something extra. You need something that's very specific for that specific virus. And that's where vaccines come in. They essentially trick your immune system into believing it has seen that virus before, even if it hasn't. And the way it does this, as Faith mentioned, is by presenting your body with a piece of the spike protein found on the surface of the coronavirus. So that protein resembles the virus enough to trigger our body to produce an immune response and produce antibodies that will protect us if we do encounter the actual virus in the future. So it's essentially giving you a cheat sheet, a practice run with the virus where you can protect yourself for any future exposure.
Sorry, can I come in here? Can I come in here and address one of the statements made by Anthony? Because I think he did make a very fair point. I'll give you that, Anthony. It was a fair point, which is, Terence, you're just saying take the vaccine. What's the basis for your position? Well, number one is this. I would say, generally speaking, when it has come to healthcare issues, number one, I'm not a clinician, and therefore I defer to clinicians. And I defer to clinicians, and the reason why I defer to clinicians is because I ask the question. So, for instance, I've got a team around me. In fact, I'm in a team. Associate Professor Donald Palmer, who's a professor in immunology, and I've also got Dr. Jacqueline McLeod. I'm in a team with them, and we're in the Black Healthcare Group. And I take advice. I don't simply blindly say I'm going to take the vaccines. And what we've done is, so we've looked at it together, we produced a fact sheet, and that fact sheet has gone out to Black majority churches. So it's not a case of me simply saying, I'm blindly going to take the vaccine. I'm going to admit, many times I've taken medication and I've glimpsed at the back of the sheet, the information sheet, and had a quick look, and we've all had a cursory look at the side effects and thought, yeah, I trust it, I'm going to have it. I'm not a biochemist, I'm not a clinician, I don't have the expertise. I can study this for a whole year, and we can all study for years. And I can tell you now, we will still have questions. And really, this boils down to one single word: trust. Dr. Palmer, it's one word. Dr. Palmer.
Tony, let him finish.
Anthony, I'm asking you to.
You're a solicitor.
Okay, Anthony, let him finish. Let him finish, and then please, and then you can have your rebuttal. Go ahead, Terence.
Anthony, you need to listen. You need to listen to what I'm saying, which is this: I am not a clinician. I'm not asking you to trust me. You need to listen very carefully. I'm not asking you to trust me. I'm telling you what I do. I trust experts. I defer to experts. I have to, because I'm not a clinician. I could study this for a whole year and I'll still have questions. And therefore, it's always going to boil down to the trust of the doctors. And that's where I think we've got a problem. And some of that problem, and I'm with you on this one, Anthony, you made a very good point at the beginning. Some of the problem is the fact that we've been bitten by racism in healthcare. And that needs to be, after this pandemic, that's something that will have to be looked at seriously.
Tony, just to answer, there's a question that's coming, there's loads of questions coming in on the question and answers. One is actually to Anthony, says, my partner who is Black has been taking a high dosage of vitamin D for over 2 years. They contracted COVID last year. She was put in an induced coma that required ECMO treatment. And we are lucky she survived today. There's the other side to the coin on that. So just to highlight, because I don't want this to turn into about vitamin D and herbs, but just to highlight, there is another side to this whole debate. And I just want to put that out there. Claudia, yours.
So, as expected, this is a huge subject. It is a subject which has dominated our lives for the last year. So we have gone over. Orin, can we have another 5-10 minutes? Let me know. Yeah,
yep,
okay.
You're good to go.
Let's go for around 5 minutes. Let's see if we can wrap this up. Dr. Ngasa, I would like to put this to you now. I know you are an organ transplant surgeon, but the issues that have come up time and time again, and from those who are completely fine, I say completely, who are fine with taking the vaccine, to those who are still having their doubts. The issue is that there is an element of distrust, some of it justifiable, in terms of the healthcare system, in terms of the way Black people and Asians are being treated within the healthcare system. What do you think needs to be done as a Black surgeon? What do you think needs to be done to deal with that?
Yes, as a Black surgeon, I would like to make it clear to our Black community that even if we seem to be on the other side, we also face the same problem like the general Black community. So we were paid today to say things which are not right, or to try to influence people's thoughts. So I don't want to dwell too much into this. I just want to make an appeal. We of the Black community, we live with comorbidities like obesity, like diabetes, like hypertension, all of which predispose us more to developing severe COVID disease. So we should be the ones to realize that we run a higher risk, and we should, we do have historic reasons to distrust the system, but for once, I think we should dwell more on our well-being and leave these conspiracy theories for a while. Let's take a break, please. My appeal is to the people in the Black community to take this vaccine. I believe putting on the balance, the benefit outweighs the risk far more. So please listen to us. We are not trying to brainwash anyone, but we do appeal for people to reason with us. Thank you. It's becoming too emotional. I'm finding it very difficult to find the right words, but I had COVID myself in March. I was one of the lucky ones who had just 3 days of symptoms. I worked in ITU in April, and at that time, 1 out of 2 patients died. 1 out of 2 patients coming to ITU didn't make it. So I've seen terrible things, and most of those people were from the BIM community. So I'm not trying to influence people's thoughts. Mine is just an appeal. Thank you.
Dr. Ngasa, I really thank you for those final words, as it turns out. I thought it would be good to end with somebody who Black people can recognise from the healthcare profession, from the medical profession, to speak to them. I also want to thank all of the other panellists for joining us tonight, for taking part in such an important issue. As I said, we wanted to make sure what was vital is that we present facts. And I really believe that people who tuned in today, who signed up to this, have been presented with facts. I just also want to say that there's a chance for you to actually tell us what you think about today's webinar. There's going to be a survey at the end. All of you guys, all you online attendees, please, please, please take part in that. But thank you to the attendees, and thank you to the panelists. Thank you, Oren and Beverly, and I'll hand it back to you, Oren and Beverly.
Thank you very much. And just myself and Beverly just want to convey our thanks to all the panelists, health professionals, patients, Mr. Channer, Mr. Cox, Reverend Pitts. It's been quite a session. I think a lot's been learnt. We've got experts out there. Dr. Price coming in at the last moment. Dr. Bright, in your presentation, it's really, really good to hear the clinical data, whether you agree with it or believe it or not. It's there. It's out there. So we're not denying things. I'm going to put a question. Oh, actually, there's a question that someone's asked, and I need to ask of the panel, especially the health professionals. The question is, have you taken the vaccine?
Yes, I have.
Is that a thumbs up from everyone?
Yes, I have taken the vaccine.
I've had
I think Dr. Price, here we go. Dr. Price said earlier that he'd just taken his, isn't it?
Right. So, and just before we finish, I'd just like to give the opportunity to Dr. Valentine Ngwa, Dr. Linda Bello, and Dr. John Ayuk. I mean, first of all, thank you. You've been so busy. There's been hundreds of questions you had to try and answer, and it's been fantastic. But do you have any comments, just quick comments?
I just wondered if they could just give us a very brief snapshot of what the questions are that you've been answering.
Yes, if I could just go first. Lots of questions about side effects of the vaccine, lots about people having palsy, lots of people saying that some of their relatives had died, lots of issues about trust, Black people and us trusting the vaccine, lots about pregnancy and fertility. Just a snapshot, but there's been hundreds. We've been trying to keep up. I don't know if my other colleagues want to say a bit more.
Yes, thanks. I think a lot of my questions were also on side effects, particularly people want to know what the long-term side effects were, and of course, which, as we know, they're still being monitored because the trial, they were approved on those 2 months of trial data. But again, those participants are still being followed up for quite a long time. But I also try to remind people that when they're thinking about the long-term side effect of the vaccine, they should not forget that the COVID illness itself could have potential long-term effect. As we're now seeing almost 1 in 10 people coming down with long-term symptoms of shortness of breath, of cardiac problems, of respiratory problems, and hearing loss, loss of taste. People are also wondering about COVID vaccine on children. Well, it's not been licensed yet for children. So somebody made a comment whether it wouldn't be the same like the thalidomide disaster in the 60s, which was totally a different thing altogether. Children are just still being under the trials now, so it's not licensed for children just yet. And of course, a lot of questions as well was why Black people are vulnerable to having the COVID, which is quite a whole big topic by itself, not just for the demography, not just for the employment where there are people facing, but their personal vulnerabilities, which is a big thing to also talk about. But those were the few things I was addressing in summary. Thank you.
Thank you, John. Thank you.
Can I say as well that there were some legal questions that I had to address as well. And the main legal question that was posed was immunity from lawsuits, and people asking, well, why has the government entered into agreements to grant immunity? And the answer is they have. Am I happy with it? No, I'm not. Am I happy with the damages, vaccine damages payment scheme? No, I'm not, because the limit is £100,000, and the threshold is quite high in proving that the vaccine caused any effects or harm to you. So the answer is yes, there is immunity from lawsuit, and the amount is only £100,000, it's capped.
Thank you.
Thank you, Terence.
And Dr. Ayuk?
So most of the questions I answered have been covered by my fellow question answerers. The another theme which emerged, which I don't think we've talked about so much, is actually the point Anthony raised about the number of, Black people involved in these trials. And this is a recurring theme, and we'll see it with every single trial, Anthony, not just these vaccines. All trials, you'll find the number of Black people represented is very, very low, extremely low. Obviously, but part of that is down to us. These trials are usually, they're done on volunteers. So people volunteer to be part of a trial. Obviously, we all know the reasons why, many Black people will be very hesitant to volunteer to be parts of trials. But ultimately, we have to change that at some, we have to change that somehow. Otherwise, we're going to be sitting here having this debate in, our grandchildren will be having this debate and saying, why wasn't I represented in that trial? We have to change it. We have to sort of get in there and, engage and change things from within.
Okay, thank you. Right, I'm going to give 30 seconds wrap up by all the physicians.
Can I just quickly say, guys, if you want to impress the Black community about the efficacy of drugs or any vaccine or any other product to the Black community, you can't come with BAME figures.
Right, we agree that. No one's disagreeing with you that. Black figures, yes. And watch this space, Tony. All I say is watch this space, because it's been clear, it's been made clear, we are a race apart from others, and we need to be addressed like that in the same way as the white community. So I totally get it. I want to give 30 seconds to all our physicians to sign up before I ask on behalf of the patients who are Andrew, Chanel, and Vanessa to give a final statement before we wrap it up. So Dr. Williams. Final few words, please.
Yeah, I would just say that the reason that we are all here and we're on this call is because we understand that the Black community has been disproportionately affected by the pandemic and by this disease that is ravaging our community. And the fear is that, Black people won't take the vaccine, they won't get that protection that their immune system needs, and they're going to end up unprotected at the end of all of this. So, I mean, there are many, many issues with the Black community and the healthcare system. And yes, we acknowledge all of that. But this moment is critical. This moment where you need to protect yourself and protect your family is critical. And it's something that each person has a responsibility to do. It's not something that you can say, oh, other people can take it and I'll be fine. Everyone has a responsibility to do their part for the wider community and the more vulnerable among us. So I'll just leave it with that.
Thank you. Dr. Philbright, 30 seconds from yourself, please.
Well, I would say that I am in a position to judge from as a clinician whether or not to have it. I've chosen to have it. I've chosen to support my family, my immunosuppressed wife to have it. And there is evidence in Black communities, not so much for the Pfizer and Oxford vaccine, but for instance, the Janssen vaccine, a large part of that was done in South Africa. So lots of Black people involved in that.
Thank you. Thank you. Dr. Price.
Yes, so my message really stems from my work with haematology patients who already are a group of patients who face an enormous amount in terms of their treatment that they go through. So on the background of seeing this group being really vulnerable to the virus, I think we just want to stress that for patients in that higher risk, the transplant patients, the blood cancer patients, we really want to protect them as best as possible, and we feel like the vaccine is the best way for them, and we are very committed to making sure that we follow things up very, very carefully. We look and assess their responses, and we make sure that it's we're representing that group, and I think as well for our patients who also have been exposed to other structural inequalities, and that coming to light in the pandemic has been really we've known about it for a long time, but it's really, really important that we address these inequalities, and things like representation is just so important. So yeah, we would say that anybody with blood cancers or hematological disorders, we do really want to get vaccinated. If you need any support or any other information, there's services with Auntie Nolan. You can get in touch with us. We can provide any extra advice if needed. And yeah, I understand it's been a really interesting talk, and it's really, I feel very humbled to be able to listen to everyone's opinion and everybody's experience. And yeah, I'm very grateful to be able to be part of the talk today.
Thank you so much. I appreciate that. Dr. Faith Udiwade, final comments from yourself, please.
Hiya. So I was just going to say that I guess the main thing I want to say, it's not my place to basically tell anyone whether they should or they shouldn't take the vaccine. What I want is just people to look at the information, look at the facts, and then make an informed decision for yourself. So for me, when I was offered the vaccine, I took it up because it's something that I thought would help me. And it's both my parents have now had the vaccine, and I'm very, very happy and pleased with that information. So it's good to know that they're protected, and that by them protecting themselves, they're also protecting the people around them that they care about as well. So just look at the facts and make an informed decision for yourself.
Thank you. And Dr. Hussefa Ademali, please.
It's incredible how a small virus, nanometer, has galvanized us as a community. I would never have met you all in this group. So it's very humbling to be among you all tonight. It's really important we take ourselves through this difficult pandemic. There are been too many deaths in our communities, too many losses. We want to get through this pandemic and address all the things that have been raised about inequalities and structural racism and so on. It's important that we continue with this goodwill, galvanize ourselves, get stronger and go forward, have the vaccination, read the information that is out there, and make an informed choice. It's important for you and your loved ones.
Thank you. And down to our free patient reps, who this is all about, really, from an ACLT point of view. Vanessa Taylor, your final comments, please.
So, yes, my final thoughts are, I think on Monday, I will take the test. I believe I'm being offered the Oxford test. My consultant has confirmed that. And I think my understanding is that they're not sure, because I've had chemotherapy, how much protection it will give me, but I believe that some will be better than none. So even if it's not the same as people who are not immune suppressant, I think some protection is better than no protection. And another thing that I feel is really, really important is, because we don't have the data, that I'm quite happy to stand up and be somebody whose details are there for whoever needs it, to say, and I know I'm one person, but if more people like me are tested and our data is available, it will help going forward.
Thank you.
Thank you. Thank
Chanel.
you.
Sorry, I just wanted to echo what Vanessa said. I think there do need to be more cases with sickle cell patients as well going forward, for sickle cell patients like myself to make this informed decision. I think today's definitely been brilliant, and there's been a few sickle cell patients and advocates in the webinar today. So I really hope today they were able to find the information for themselves so that they can make their informed individual decisions. And I just want to say thank you to everyone who's contributed today. You know, watch this space. I'm still unsure if I'm going to take the test or not, but having everyone on this panel today has added invaluable experiences and invaluable knowledge. So I'm going to take this away from me. So it's more looking like a 60-40 for me, you know. So I just want to say thank you to everyone on this panel.
And last but not least, the legend that is Mr. Andrew Cole.
Oh, no, thank you very much for obviously the debate today. Very interesting. I'm more informed on a lot of different things now. Regarding me and taking the vaccination, well, we'll have to wait and see, but it's been really interesting and it's given me a food for thought.
Thank you.
Just before we finish, we're going to
do the poll, and we just want to ask all of our registrants, they got it up now? Yeah. So the poll's coming up now.
30 seconds.
You got 30 seconds to say whether or not, having participated in today's webinar, if offered, will you take the COVID-19 vaccine?
Interesting figures are appearing. Original, yeah. Okay. So I'm going to do a comparison.
Okay, so what we're seeing is 44%.
5 seconds left.
Oh, wait a minute, we've got a few more seconds, sorry.
2, 1.
Okay, So what we're seeing is 44% saying yes, 30% saying likely, 13% unlikely, and 13% saying no.
Okay, the no's have dropped slightly. The unlikelies have dropped, I get, from 21 to 13%. The likely has gone from 22 to 30%. And the yeses were 40% at the beginning, they're now 44 at the end.
But going with our numbers, some people have dropped out now because we've typically gone over. So
yeah, but we've still got what, hundreds and hundreds of people still on there. So
registered in.
Yeah, still registered, still online. So coming to the end, I just want to quickly just highlight the message from the ACLT, which is about looking for lifesavers, the kindness of a stranger, which is what, as you know, our personal story, our Daniel, was all about looking for the kindness of a stranger. He found one eventually after 6 years in Detroit. Another Black person of African descent, African American descent, came forward and helped him. We want to do the same for ourselves if we can, if we offer the vaccine, not only to help ourselves, but to help humanity in general. But it is down to choices, just like the bone marrow, stem cell, blood, and organ donation, it is choices. But today is all about giving the facts. And just to take that forward, heroes, if you look inside our heart and souls, there's a hero waiting for inside of all of us, waiting to break out and do something spectacular. And this is an opportunity to become the ultimate heroes. There's a picture of Annette Carr, a myeloma patient. She recently had a jab.
She had her first jab about 6 weeks ago.
Okay.
She's waiting to have her second jab. Well done, Annette.
Yeah, and with permission, this is my mother.
Let me say this. This is Orange Mum. She's 90 years old. I took her to have her vaccine about 8 weeks ago. She was literally pushing everybody out of the way because she wanted to be the first one.
Much, is it? Much, no.
There you go. So she's waiting to have her second jab.
Reaction afterwards. Yes.
And the final one is my better half. Was it 2 Fridays ago?
2 weeks ago.
2 weeks ago.
I think I was bumped up the queue because I'm not old enough, but somehow I got a call, so I took the opportunity.
So just finishing up, if you want to support the ACLT in any shape or form going forward, aclt.org is our website details. At ACLT Charity, you can find us on all social media platforms. Big thanks to the Caribbean and African Health Network, CAN, Kidney Care UK, the British Islamic Medical Association, the Sickle Cell Society, and others, Unsickle My Cells and others. Thank you very much for being part of this and helping to create the content, especially with the questions that we'll put in there in terms of what we are all thinking about. If you want to find out more about us, fundraising, info@aclt.org.
Yeah, and also please follow us on social media. We are at ACLT Charity, at ACLT Charity, all one word.
Yeah, so if I can quickly close this down, if I can get my mouse to stop sharing and bring everyone back. Just really wanted to say thank you to all of you. I know we've gone over time, but we've still got a healthy amount of people still with us. First, really want to say thank you to the panel.
Thank you all so much
for your time. It's really meant a lot to us. Thank you to Charlene, who was here at the beginning, the keynote talk. Thank you to Claudia for our fantastic moderator. Just thank you so much for agreeing to do this.
Thank you. Claudia took a day's leave for this. Really, really appreciate your time. Thank you.
And we're going to debrief briefly for 10-15 minutes. We're going to email you guys so we can quickly have a debrief, the physicians and everyone. But thank you so much.
I just want to say thanks to everybody. I want to say particular thanks to Anthony Cox.
Yeah.
Because I think he might have felt like a bit of a lone ranger today, but we needed to get your side across because a lot of people have your views.
Yeah.
And well done for coming forward and putting your points across. I just hope that in some small way, we will, you know, ultimately people have to make up their own decisions about this. And myself and Norrin, we like to work on facts, proven facts. And so we're hoping that everyone moving forward will just get the correct information that they need in order to make informed decisions, as we all are trying to do. So thank you.
Thank you, everyone. Thank you to our audience and the great questions, and to everyone on this panel. Stay safe, stay healthy, and we'll be in touch, and look after yourselves. Thank you so much. Good night.
Good night.